The hip replacement, it's a quite miraculous surgery, especially thinking about where we've come from our past, and all the innovation and designs that we've kind of gone through. It's one of my favorite operations because of how well patients do. I usually answer that by two different ways. First, I tell them clinically they have to have radiologic signs of arthritis of the hip. That means usually bone on bone or close to bone on bone arthritis of the hip. The second category is that they have to have pain, hip pain that's related to the hip, meaning that's not coming from the back, it's not coming from the thigh, it's coming directly from the hip, which typically manifests as groin pain, but not necessarily always. And it's important when you see your doctor that they perform a physical exam to ensure or confirm that it is coming from the hip. And then once they have arthritis or pain that is severe enough that it affects their activities of daily living, then you can consider possibly having a hip replacement. So a hip replacement is actually a ball and socket joint. It's pretty simplistic. And so what you do for the pelvis side or the acetabulum side is you actually will remove, by reaming, remove all the bad arthritic bone, and you implant a socket that's usually titanium into it with a usually plastic liner or so. And then the femoral side, if you can imagine the femur is like a cylinder, and you put these broaches in that increase the size of the hole, and you insert it into the stem into the femur, and then you put it together like that. And that's how you do a hip replacement. We've been doing same-day operations where patients go home the same day for actually several decades. Not everyone can go home the same day, right? But we have these resources, we have these evaluations by anesthesia and our team to see whether or not they are a candidate to go home the same day. And if they can, then they can safely go home. Typically, they walk a little bit more every day. And what I mean by that is they walk about 100 to 200 additional feet every day. So the first day after surgery, they're only walking 100 to 200 feet. Second day, 200 to 400. Third day, 300 to 600, and so on and so forth. Every day, they're walking a little bit more. And so by 6 weeks, if they're walking a mile, that's great. In the first couple of days, the pain is the greatest because of the pro-inflammatory response after surgery. We give you all sorts of different multimodal medications to make sure that the pain is tolerable. I didn't say that there's no pain. The pain should be tolerable. And so if the pain is not tolerable, then you should probably take something more, and we give you all different medications to kind of help choose. And then after a week or so, the pain gets better. And that will be the theme of your surgical journey going forward. So every day will get better. You'll be able to walk a little bit more, the pain will be a little bit less, and so on and so forth. Our academy guidelines say that the patient shouldn't run, and the patient shouldn't do or be engaged in very heavy Olympic-style weightlifting because it can wear the prosthesis out. But aside from that, there's not many specific restrictions. That being said, the surgeons may have very specific restrictions for you just because they want you to, they're thinking in the long term. And so, if you follow their instructions for the first 3 months or so, then in the long term, once the capsule heals, then they can expect, and you can expect a very long and satisfying outcome. The short answer is it can last anywhere between 20 to 40 years. The wear simulators suggest that it can last even longer. I also answer that by saying the realistic revision rate, meaning every year you have the hip replacement, you probably have about a 0.5 to 1% chance of undergoing an operation, another operation for that hip. So if you're 60 and you have the hip replacement and it's and you want it to last 30 years, then you probably have somewhere between a 15 to 30% chance of having another operation in the next 30 years. And so I talk to patients about that, and they kind of look at it and say, okay, you know, if I qualify, if it's affecting my activities of daily living, that's a risk that I'm willing to undertake. Some of the most common reasons for undergoing another operation, the number one reason is infection, the second one is dislocation, and the third one is the implant loosens. And so one of those three things could potentially happen at a risk of 0.5% to 1% per year. And it's important to get an X-ray from an orthopedic surgeon every 5 years or so to make sure that it's wearing appropriately.